Alrighty. My name is Melanie Farkas. I'm the program manager for the HPV Quality Improvement Program. Thanks again for joining us. Dr. Fitch, would you like to introduce yourself?
Yeah, I'm Jill Fitch. I'm one of the intensivists who is actually in the cardiac ICU right now, and I will be answering a phone call. But I've been helping as the medical control for this project. And let me get this phone call.
Put yourself on mute. And then Dr. Anzels, would you like to quickly introduce yourself?
Hi, everyone. I'm Samantha Anzels, and I'm the Quality Improvement Consultant and Data Person for this call and project.
Just a quick look at the agenda for today. We have a really great presentation today by Dr. Technos on HPV vaccine impact on other cancers. And then the end of our conversation will include the data that we've received so far. So without further delay, I'm really excited to introduce Dr. Ted Technos. He actually graduated from Harvard Medical School in 1991, completed his residency at Vanderbilt University Medical Center as the head and neck oncology skull base and microvascular reconstructive fellow. Dr. Technos returned to his home state of Michigan. I'm also a Michigander, Dr. Technos.
All right.
Go Blue. And spent the next 11 years working for the University of Michigan Health System. Moved to Ohio in the fall of 2008 to join the team at The Ohio State University, becoming the division director of the head and neck surgery at the Arthur G. James Cancer Hospital and Richard J. Solov Research Institute. As of 2014, Dr. Technos assumed the role of chair of the Department of Otolaryngology, Head and Neck Surgery, and holds the David E. Schuler and Carol Schuler Chair in Otolaryngology. On a national level, Dr. Technos serves on the Head and Neck Committee of the NRG, is a governor of the American College of Surgeons, and also serves as secretary and treasurer of the OSU Physicians, Inc. I'm really excited for this presentation. I've seen Dr. Technos present a few times at some various HPV conferences, and I think the information is really key to raising HPV rates in Ohio. So, Dr. Technos, I am going to attempt to promote you to co-presenter of the webinar and hand you over control of the slides. Sometimes this does not work, so if it doesn't, I will just switch your slides for you.
Okay, sounds good.
Let me know if you get an alert on your screen that says anything about taking control or.
It said that I'm connecting to the server. Can everybody hear me okay?
Yeah.
Okay, good. This looks good. So let's see. So can you see my cursor here? I'm in the middle of my slides, I guess.
No, let me see.
Well, I can just ask you to advance them if you'd like. You know, if that'd be easier.
I just pushed the button to give you control of the desktop, so it should hand it over here.
I think I got it. Let me try it. So trying to click on the advance button. Oh, there it goes. I think I got it. Great. Well, thanks everybody for the opportunity to speak today. This is a subject that has become a bigger and bigger part of our practice as head and neck surgeons, and it's something that, as you'll see, as recently as a couple of decades ago, wasn't as big of a topic in our field, but has become really front and center of taking the best care of our patients. So what I'm going to talk about today, particularly as it relates to other cancers, is what we call oropharyngeal squamous cell carcinoma. So in the lay press, you may have heard about HPV and its effect on oral cancers, but really what we're talking about is cancers that affect the base of tongue. Can you see my pointer there? Or is that just, can you see that?
Yes, I can.
Okay.
Yes, we can see it. Yep.
So the base of tongue is right in the back of the tongue. It's not the oral tongue, which is what the press is talking about, oral cancers. It's really the back of the tongue, and these are the lingual tonsils as well as the palatine tonsils, which are the typical tonsils that we see in young individuals as well as in adults' throats. So this is the area of malignancy that we're going to be talking about. Specifically, this is what they look like when I see them in the office. So this is a patient who came in, and what I'm pointing at here is this is, as you can tell, the abnormal growth here. The tongue, the back of the tongue is supposed to look like this, but you can see this has been replaced by this large mass, which is pushing back on the epiglottis. So we're looking from above, and the larynx is down in this area. So it's pushing the epiglottis posteriorly, and it's really replaced about 2/3 of the base of tongue. So this is an oropharyngeal carcinoma. And in the past, when we saw these tumors, these were our typical patients. You know, they were people who smoked, drank, and that was about 90% of the patients that we saw. Occasionally, we'd see people with these immunosuppressive syndromes, if you will, whether they be congenital or acquired, and some rare individuals who had some vitamin E deficiencies, as in Plummer-Vinson syndrome, or some oral hygiene issues, nutritional issues, and rarely syphilitics would get these types of cancers. But overwhelmingly, our patients were individuals who were heavy drinkers and smokers, the classic VA population, if you will. And in those individuals, sorry, this went too forward. In those individuals, we saw, and this is at 5 years, and I'll leave my cursor there, a survival rate that really depended upon how soon you were able to catch these malignancies. So if you caught them early and they were in stage 1 and 2, that's individuals who didn't have lymph nodes in their neck. Cure rates were around 70%. But most of our patients would come in with lymph nodes in their neck or large tumors. So that previous tumor I showed you was a stage 4 tumor. So cure rates for these individuals would be around 30%. But then in the 90s, we started to see a trend where we'd see people with stage 4 tumors, and we were curing them at a very high rate. And these were people who weren't smokers and weren't drinkers. And that's when it was identified that HPV infections are the cause of those malignancies. That really started, as I said, to be first identified in the 90s. But the more we looked for it, the more we could find these patients who were either light smokers or former smokers or never smoked at all. And they would get these cancers and behave in a manner that was similar to what we saw with those smokers and drinkers. So this was our classic patient that I had told you about, pre-1990s, if you will. It's typically an older man who was a smoker, who was a drinker, who was malnourished, and who had poor oral hygiene, tended to come from a lower socioeconomic status, and had on pathology keratinizing squamous cell carcinoma. What we soon saw, though, is that our new patients looked like this. They were 40-year-old men who were very highly educated, were not smokers, not drinkers. Males outnumbered females, by the way, about 3-to-1, and had a pathology that was squamous cell carcinoma but wasn't keratinizing. It was what we call poorly differentiated or basaloid. And these patients would have very small tumors with big lymph nodes in their neck. So you remember previously I said lymph nodes in the neck portend a poor prognosis, but these patients do remarkably well as long as they weren't smokers. So what was seen is that in these individuals who were HPV, where HPV caused their disease, their cure rates were much, much higher. As you can see, there was as much as an 80% improvement in survival in patients who had HPV-related malignancies over those who were smoking-related. And the treatment for these was predominantly chemotherapy and radiation therapy. And what I'm showing you here is a pre-treatment tumor and a post-treatment tumor on the right. So the pre-treatment tumor is a very large mass that's involving nearly 2/3 of the base of the tongue, is just above the larynx. And then post-treatment, it's completely melted away. You know, you have a normal tongue remaining on this side. There is some swallowing difficulty, which you can see with some pooling of secretions there, but the cure rates in these patients were much, much higher. This was the original patient that I showed you at the start. He was an HPV-related tumor, non-smoker. You can see the tumor melts away with chemo and radiation therapy and is replaced by scar tissue, and the tumor goes away. Remarkably, the survival statistics on these patients is exceptionally high. So you recall in that earlier slide, these patients would survive about 30% of the time, whereas in smoking and drinking related tumors. But what we saw is that HPV positive patients who developed these tumors and did not smoke, even with stage 4 disease, had 93% cure rate, which is really unheard of differences. And you can see if they were smokers and had HPV, because certainly HPV doesn't exist in a vacuum, their cure rates dropped down to about 75%. And then people who developed these tumors circa 1990 had about a 30% cure rate if they didn't have HPV in their tumors and they were smokers. So why is this important? You know, we can break these patients down into sort of a low, intermediate, and high risk group on survival, whether or not they had HPV in their tumors, and really be able to give predictive numbers to the patients with regards to their cure rates. However, it soon became apparent that these were all preventable diseases, clearly, which is a big paradigm shift in our specialty. So this is what the typical tumor we see now is when they have HPV. It's in the tonsils or the palatine or lingual tonsils. It's poorly differentiated. They usually have a very small tumor in the throat, which causes very few symptoms. So sore throat is not as common as it used to be for these cancers, and change in voice and so on and so forth. But they develop a painless mass in their neck. It's the first sign. Sometimes the tumor is so small it's unidentified in the tonsil or the back of the tongue. And this entity now has a distinct profile. So we know that the HPV positive patients are very different from the HPV negative patients. And in summary, when you look at tobacco and alcohol use on the bottom for HPV negative patients, the more tobacco you smoke and the more alcohol you consume, the more likely you are to develop these malignancies. The profile and also the worse your oral dentition is as a surrogate for poor oral health, the more likely you are to develop these malignancies. But in HPV positive patients, it's really directly correlated to the number of sexual partners you have and the amount of marijuana that was smoked in a person's lifetime. So those are the two risk factors, if you will, for these HPV positive malignancies. The question is, how prevalent is this disease? So we are seeing the end product, but how common is HPV infection, and how often does it proceed from infection to malignancy? And these are tough answers, but we were able to screen patients, or I should say the public, and by the public I'm talking about, and you'll see the numbers, normal individuals who don't have malignancy, to see what the rate of infection was. So what we found is, at Ohio State specifically, our college students, and we took a sample of about 1,000 students who were walking into the gym at Ohio State, and had them spit in a cup. 8% of them had active oncogenic HPV in their saliva. In the adult population, it's between 5, and this is the normal, asymptomatic adult population, about 10% rate. In the hospitals, that rate jumps up to about 18%. In patients with HIV, it's even higher. Women who have genital HPV, it's higher, and so on and so forth. The spouses of known cancer patients, is about a quarter of them have oncogenic virus in their saliva. So the question is, how many of these folks go on to develop malignancy? Fortunately, let me go back to this slide. Most patients, when they get infected, have about a 2-year period where there's active virus in their saliva and where it's contagious. But the vast majority of us essentially clear that infection within 24 months. There is, however, a population that remains infectious, if you will, for a longer period of time. Then there is a latency phase of about anywhere from 20 to 50 years where the virus is episomally located in the cells of the tonsil and the base of the tongue, and then can reactivate and cause malignancy. And as I said, that's usually a latent phase that is still yet to be defined. So most of these infections occur due to HPV 16, 18, or 31, and the large percentage of HPV-related malignancies in head and neck cancers are HPV 16, 92% of them, and then HPV 18 makes up about 8%. And then a little bit under 8%, and then there's a smattering of other HPV types. It's transmitted by oral sex, to be sure, but then also just an infectious individual swap and spit, if you will, with somebody else. The majority of them, as I said, are cleared, but some in a percentage of individuals, you're infectious for longer than 2 years. So our typical, I'm sorry, clearing my throat here, but the typical individual in the United States is exposed to these viruses in their teenage years. And about 80% of men and 50% of women are exposed at some point at some point in their lives, and the highest rate is really in the teenage years. And what you see here is the prevalence of HPV in individuals who are more or less sexually active. And you can see that in men, that prevalence peaks out at about age 20 and stays pretty stable through the adult years. And women are much, much less likely to have prevalence in their saliva. And the thought there is that since in many women genital expression precedes oral contact, that there's some passive immunity that occurs. Now, the burden of this disease is what this slide shows. So in men, there are, you can see the percentages along the top here. There's about 5% of individuals that have active infection in ages 14 to 20, but it stays pretty consistent at a rate of about 10%, and it's higher in individuals who have more partners. And the burden is really what's impressive here is there is about 8 million individuals who are chronically infected with this disease in the adult male population. The female population is much less, and you can see only about 1% of females have active chronic HPV infection. Some of this may be due to vaccination rates. Some of it may be due to that passive immunity. There are marked differences between men and women. Again, I just want to point out that there's kind of a cutoff around 6 to 8 partners with regards to the prevalence of the disease, and it's much more common to have chronic infection in men compared to women. Now, how dangerous is this infection? What this shows is the risk of individuals with HPV infection developing a malignancy. And to put it in perspective, and this is the fold change, the overall risk. If someone is a smoker, your adjusted risk is about 4, meaning you are 4 times more likely to develop a malignancy than somebody who is not a smoker. If you are an alcoholic, your risk is also about 4 times higher than a non-drinker. If you're both a heavy smoker and an alcoholic, you have about a 40-fold higher risk of developing malignancy. But HPV, you're 50 times as likely to develop a malignancy versus somebody who is not HPV infected. So you can see the story here for vaccination is incredibly strong, as this is more dangerous than being an alcoholic and a heavy smoker. So what's the incidence of this disease? What you can see here is that since the Surgeon General issued his report in 1969, and there's usually a 15-year lag to tobacco smoke and malignancy risk, you can see there's been a drop-off in HPV unrelated malignancies pretty consistently at a rate of almost 2% per year nationally. But the rate of HPV-related malignancies began to skyrocket in the 90s and really early 2000s. And currently, it's going up at a rate of 5% per year. And you may say, well, what changed? Remember, this is a latency of about 30 years, so changes in sexual activity, if you will, in the 60s is really what's resulting in this change now in the 90s, 2000s, and so on. What we used to see, about 18% of our cases were oropharyngeal cancer. Now this is half of our cases today that are HPV related, and of those, half of our new cancers are oropharyngeal, and about 90% of those are HPV related. And it's really a peak. It's a bimodal peak of when people are infected. It's usually in their teens and early 20s, and then a second peak in the 60s, late 50s, early 60s. And you can see the lifetime risk of cancer goes up with increasing age. So much so that if you follow cohorts over time, the more elderly that individuals get, you can see the rates of malignancy are skyrocketing. So normally I quote patients a risk of about 5 per 100,000 in developing this malignancy, but what we've learned over the years is the longer you follow these patients, the more likely they are to develop a malignancy. And people who are in their 70s and 80s, 30 out of 100,000 develop these malignancies. And I think it's really the HPV genes getting inserted into the DNA at a critical hotspot is what determines when they develop that malignancy. So the unlucky ones get them early. Others, it's when it intercalates in the DNA near a genetic hotspot. The rate of this is going up. The Swedes have been following, and they have tumor banks dating back to the 70s. And in the 70s, only 23% of these cancers had HPV in them. Their 2015 data is 93%. So you can see even between the year 2000 and 2015, it's gone up dramatically. And this kind of shows the increase in the number of cases. In the United States, between 1988 and 2008, there's been a 300% increase in this malignancy in the U.S. population, and it's accelerating. What this slide shows is that for lung cancer and for oral cancer, which are clearly smoking-related diseases, the incidence has been decreasing as shown on the left side, but for these oropharyngeal cancers, the incidence of these malignancies is increasing. So what about vaccination? I'll do this I'll finish up with this. The vaccines would be incredibly effective for this type of malignancy because HPV-16 makes up 90% of the cancers in this area, and HPV-18 makes up about nearly the rest. So it would be targeting exactly the types of strains that we would need to prevent. But as we all know, the uptake rate by gender isn't keeping up with what we would like to see. So in 2013, about 68 or nearly 69% of women had been vaccinated. And although it's improving, it's still only 42% of men have had at least one of the shots. The amazing part is that if we could get 90% of the female population vaccinated, it would nearly knock out this disease, certainly by herd immunity. But we know that we need to have young males vaccinated as well. And what you can see here is in those who were vaccinated, there is a marked reduction in not only the malignancies, but the infection rate. And you can see in oral cancers, it completely abrogates the disease if patients are vaccinated. And what this final slide shows is that this vaccine is incredibly effective. And this is looking only at external genital lesions, but it's remarkably effective. And when you include 6, 11, 16, and 18, and it completely is effective. And this is for genital lesions. It's even more effective for oral lesions. And this last slide just shows how in genital lesions the vaccine is highly effective with very few benign acumen condyloma developing, and certainly the early data for oral cancers that it's completely effective. And in cohorts that have been studied where vaccine uptakes were very high, there is essentially zero oropharyngeal malignancies present in those populations. So if I can make a case to you today, HPV-related malignancies are an epidemic.
Sounds like
okay, great.
Thank you so much.
Thank you, everybody.
Everybody. Data, or you can conclude your time on the call, whatever works best with your schedule.
Thank you very much.
You're welcome. All right. I don't know if Melanie can hear us, but what I'm going to do is advance to the collaborative data slides and proceed us through the remaining portion of them. I want to just reorientate us to, let me see if I can make this bigger. I'm having a hard time seeing. The key driver diagram that we use throughout this collaborative, and looking at the purposes of what we're trying to accomplish by increasing the initiation rates for those that are eligible for the HPV vaccine and doing so by 10%, that we're working on, and we've kind of already accomplished the remaining two goals based on where everyone was when they started off, was having providers strongly agree that they would strongly recommend the HPV vaccine and that they would feel confident in addressing parental concerns. And if at any point that is not the case, please reach out to us and we can make sure, whether it's resources or strategies, that we can help equip you with the things necessary to accomplish those final two SMART aims. So chart review tool has not changed. You can continue using that as you have been the past couple months to work on the data that you're collecting. And just to highlight what is going on in aggregate, and this is something that you can always pull based on where you are in your cycles of data by analyzing your data, including the cycles that are of interest. And then what you can do, in addition to noting the goals that we have set, as well as the items that are happening within your practice, you can add all participants or project or group data to this, and all those lines will appear on one graph And that is something that we can always converse about individually, about what strategies others are employing, or something that we can discuss during our time together on our final action period call when we're going through sustainability. So with this, this slide and the next slide look at our initiation rates for those 11 and 12-year-olds. And what I saw when I looked through the data, and I'll comment it on a little later, is the breakdown of when the data that I had to date, those HPV series were initiated, and how that's reflected here, because this data that we're looking at really takes into account the recommendation that came out in October, so working to get us towards that. And we're bumping back up to that, and of course with random audits of our charts, all the patient population may not be reflected, but hopefully as we progress through and get more best practices into place, this will help us advance those items around each and document.
Hey, it's Melanie.
Population. Hello. And then our initiation rates for our older adolescents, those 13 to 17-year-olds, are performing a little lower than our 11 to 12-year-olds. And again, this is based on the new recommendation after 15, or younger than 15, having the 2-dose series, and then older than 15, having the 3-dose series with different timing. Looking at our series completion rates, I think there's room for some improvement here, and maybe some lessons that we can learn based on what's happening with our older kids, since those are a little higher. And we had one blip with 4 adolescents, with that population having 75% of their series being complete. But it looks like it's around the 20% mark of having those individuals completing their series, be it timing and spacing, having a little more time to advance through these, given they've had their 11 and 12-year-old initiation, and then working to complete those 3 doses over a longer length of time. And then invalid vaccine administration. So for those less than 15 years old, getting that second dose in, this really reflects, again, all of our data was prior to when I had reviewed it in February, charts that had initiations of the immunization started before October. So doing the 2-dose series will not necessarily be reflective of your whole practice, given that the timing of that first and second dose is different for this new recommendation. So that is something to just take into account, and it should start to drop as we get closer towards the end of this collaborative and see that closer to 0 as we start to complete those less than 15 and then start to bring our less than 15 up to that new CDC recommendation. And then, of course, it's not really an issue with our older adolescents and having that second dose improperly administered, so that doesn't really factor into here, but it didn't seem to be an issue or an item for anyone to work on with our older population, because you guys are getting the spacing and everything appropriate there. So I think it's just getting some of that runoff from the time prior to the recommendation going, and then we'll get back to where we were. So timing between doses. The data that I had reviewed was everything baseline and cycles entered prior to February 23rd. So all the series that had been initiated that I had dates for, that's one thing that wasn't fully noted for those that were in the process of completing their series, having those date boxes completed and indicated with an appropriate date. So that's one thing to kind of pay attention to as you're entering your data, to list the date when there is an opportunity to do so in that free text. But for the series that we had, they all occurred before October and that new CDC recommendation. Almost 30% of those less than 15 were eligible for the 2-dose series, and we can see some of that reflected in that invalid spacing of doses. 70% of those individuals were that were less than 15 will need to have that 3-dose based on that timing between their first and second dose. And I think that falls in line given that everything happened prior to that new recommendation coming out. And then looking at some of those older kids that had started, of course, they're going to be needing the 3-dose series, and that's kind of the breakdown of those remaining individuals that were in that data set that had dates for starting the HPV series. And then just looking at the timing between the doses, and then this really speaks to those bullet points above, the spacing for those individuals was just under 70 days between the first and the second dose for those younger than 15 years. So again, we have to open up that time frame for those younger than 15 and then complete the 3-dose series for those younger than 15 that have their first dose provided basically within 2 months.